So I will approach this topic as what happens in normal aging, what is pathological aging, what is cognitive reserve and normal repair mechanisms, and what can be sustained and mechanisms to sustain, and the philosophy of living. So what is the aging? Aging is a phenomena which represents a mixture of cellular and systemic physiological changes intrinsic to the species. All of us know that each species has got a different expectation of life and environmental factors which interact with these processes. And aging probably starts at conception or at birth, or even when the zygote is formed. There is a controversy in deciding whether it starts when the zygote is formed itself. But at a phase, this aging starts, but decline doesn't happen. But at a phase, decline starts. And that decline phase ends in senescence. Now, all of us know that there is active synaptogenesis in the neuraxis approximately till the age of 8 years. And from the age of 8 to 30, there is a stationary phase, unless there is a disease process. And after the age of 30, there is a steady decline in the synapses and neuron count. So one Purusha year is approximately 120 years. And if all adverse environmental influences are removed, that is the average period for which a human being can live. So how these mechanisms happen? One is telomere shortening. We know that in the chromosome, there is a telomere. The rate of shortening of the telomere determines the fastness of aging. Then random damage, multiple tissue damages can happen due to exposure to environmental radiation, toxins, drugs, infections. So that is second mechanism, random damage. Then spontaneous mutations. Normally, there is a cell cycle time, and mutations can change the cell cycle time. And error catastrophe. What is that? Error catastrophe is, you see now, instead of producing the gene code for progressive improvement in the cell function, it can do the opposite effect. So the gene products will do opposite effect or apoptosis, death. That is error catastrophe. And pleiotropic antagonism, multiple mechanisms by which cell growth is antagonized. And you have got growth inhibitor genes and suicide genes. So these are the things that lead to slow loss. So telomere shortening, random damage, somatic mutations, error catastrophe, pleiotropic antagonism, and growth inhibitors and suicide genes. These are primary mechanisms. Secondary mechanisms are infections and environmental factors like radiation, autoimmune disorders, hormonal and nutritional factors, malignancies, and metabolic disorders. So all these put together, they shorten the one Purusha year. So what is this thing called apoptosis? Apoptosis is the phenomena which leads to programmed cell death. All of us know that none of us are immortal. Some of us live longer, some of us live shorter, but none of us are immortal. So that programmed cell death is determined by the phenomena called apoptosis. And this happens by some changes in the cell. That is nuclear condensation. The nucleus condenses. And blubbing, there are some vesicles appearing, and these vesicles join together, form a megavesicles, and they rupture. Then chromatin shrinkage. And by these processes, about 50 to 70 billion cells die every day. 50 to 70 billion cells die every day in the human body, not the brain, human body, whole body. And there are death ligands, death receptors, and initiator cascades and effector cascades. These are enzymatic cycles which lead to apoptosis. Death ligands, death receptors which act through death receptors, then initiator and effector cascades. Then you have got mitochondrial damage, cytochrome C mediated damage, DNA damage due to various factors, and excess caspase degeneration, and defective caspase autoimmunity and cancers. So these are the various factors which accentuate apoptosis. So how are you going to protect this? What is neuroprotection? We saw the mechanisms in brief, how damage happens due to primary default mode factors and secondary environmental factors. And so how are you going to prevent this? The neuroprotection is the mechanism which prevents neuronal death by intervening in and inhibiting the pathogenetic cascade. We saw the negative initiator caspase, gene, error catastrophe. So this pathogenic cascade is should be inhibited. That results in cell dysfunction and eventual death. So this cell dysfunction producing pathogenic cascade should be inhibited to get neuroprotection. And neuroprotection is an effect that may result in salvage, recovery, or regeneration of the nervous system, its cells, structure, and function. And the agent should limit nerve death after a CNS injury. This agent should limit cell death. Once injury has happened, one it can prevent an injury, or once injury has happened, it should limit the nerve death and protect the CNS from premature apoptosis. So this is how a neuroprotective agent should be acting. Primary pathogenic cascade should be inhibited, and it should affect the way in which all the three processes of creation, destruction, and sustenance happens. And once injury happens, the damage should be limited and premature apoptosis should be prevented. Then only it could be an effective neuroprotective agent. So what is cognition? Cognition is the highest level of intellectual function available for formal testing methods and includes executive function, learning, memory, visual and verbal analysis. Its foundation is a network of 108 billion nerve cells capable of 10 to the power of 2,783,000 interconnections, which when stretched is higher than the total number of atoms in the universe. We have gone through the era of diagram makers and lumbers who try to understand this curious function. And Gray's Anatomy 1973 edition states ancient civilizations of the world knew nothing about neurology. Imagine Gray's Anatomy 1973 edition says that ancient civilizations of the world knew nothing about neurology. But Charaka Samvidya speaks about nervous system in the BCs. So how advanced Indians had been, that we should remember at every step. And this abstract cognition was the essence of ancient Indian spirituality and medicine. We did not depend on industrialization and instrumentation. Our ancient forefathers depended on cognitive function exploitation in disease modification. So aging and cognition, approximately 33 stem cells make the CNS by signaling, wiring, perceiving, connecting, inhibiting, completing, and interacting. So the stem cells make so many types of permutation combination, resulting in various differential functions. Then by the time of 65 to 80 years, insomnia, retrieval defect, fatigue, inability to attend to several stimuli begins, which is considered as normal aging. So most of us who are retired may have some varying degree of these kind of symptoms, and which indicates that normal aging has started. And in normal age-related cognitive change, vocabulary and function remains unaltered. They do not become altered in normal aging. Although performance time may be prolonged, you may take little more time, but your vocabulary and other functional capacities do not change when you call it as a age-related change. And what are all these stem cells? The 33 stem cells, which are the primordial cells, which lead on to the nervous system, are endogenous neural stem cells and pluripotent stem cells, which can differentiate into nerve cells. So they may be pure neural stem cells, or they may be pluripotent stem cells, which differentiate into nerve cells. And dysfunctions of endogenous stem cells and the specialized environment in which they grow leads to disease and aging. And they are in the ventricular, subventricular, and in the hippocampal regions. So normal adult brain weighs about 1,230 to 1,275 grams in females, and 1,350 to 1,410 grams in males by 12 to 15 years of age. By the age of 80, there are approximately 20% decrease in the blood flow to the brain and about 233 grams of brain weight loss. So when a patient claims memory problem, but not significant to be classified as dementia, how to differentiate whether it is subjective cognitive decline or normal aging or just the patient is feeling? So these are questions we should know. And what is this cognitive reserve? It's a broad concept which could be responsible for reduced susceptibility to impairment. Even though there is a disease, the functional impairment is reduced due to individual characteristics like genetics, increased synaptic or neuronal capacity, greater efficiency in engaging brain capacity, or use alternative strategies. So if you have more than 10 school years, even when the brain declines due to some genetic disease, it has got a capacity to be functionally efficient because of the reserve produced by higher synapses induced by higher educational status. So one strategy of neuroprotection is education. So mechanisms in homeostasis. Brain is the most mysterious organ in nature, and our ability to understand its physiology and chemistry is improving now, but it is not even a small fraction of what remains to be understood. Role of epigenetic factors, micronutrients, plasticity are gaining importance. And what is this plasticity? So neural plasticity refers to the capacity of the nervous system to modify itself functionally and structurally in response to experience and injury. And it is an anti-excitotoxic agents improve neural plasticity, and apoptosis inhibitors. Apoptosis is premature programmed cell death. That is apoptosis. And inflammation will produce autoimmunity and inflammatory death. So anti-inflammatory agents. Iron chelators. You know, iron is an oxidative substance. So it will produce oxidative damage. Then neurostimulants, gene therapy, stem cell therapy. These are the various therapies by which neural plasticity can be enhanced. So plasticity is changes induced by neural plasticity has been described at various levels. So neural plasticity changes can be, so it's not regeneration. When degeneration is taking place, neural plasticity can bring about functional improvement against the decline. And this is at levels of cell, at molecules, and at networks. So this plasticity changes can be seen at cellular level, molecular level, and network level. So the possible agents which will affect this cellular, metabolic, and circuit changes of plasticity is growth and neurotrophic factors. So they are central nervous system cell promoting neurotrophic factors. Then antibodies, that is anti-VEGF, vagal derived growth factors. Then gene transfer, antioxidants, hypoxic ischemic neonatal inflammatory mediators. So even when children suffer hypoxic ischemia of same degree, all the children are not left with the same degree of damage. Some children are severely damaged, some are less damaged due to the endogenous inflammatory mediators. So modulating those mediators might be neuroprotective. Then excitatory amino acid receptor agonist and antagonist, free radical scavengers, and platelet activating factor antagonist. Then glutamate receptor antagonist. We know that glutamate is an excitotoxin. So antagonist for that receptor. Then substances which target specific intracellular pathways. The neuromodulators, neurotransmitters, G-protein coupled receptors, drugs like barbiturates, propofol, xenon, ketamine, anesthetic neuroprotectants, all are various methods of possible neuroprotection. So what are all the sources currently available? That is, one is called brain cocktail. What is this brain cocktail? It consists of several components which is a mixture of free radical scavengers, modifiers of nitric oxide activity, metabolic inhibitors, calcium and iron chelators, and drugs that affect the excitatory amino acid system and which are being explored in the patients of traumatic brain injury. Then compounds that may inhibit CNS necrosis. So brain cocktail is a combination of various substances which antagonize the mechanisms involved in traumatic brain injury. The next is the compounds that inhibit CNS necrosis or apoptosis. Then anti-inflammatory cascade promoting progesterone and other steroids. Then among the pharmacological candidates for neuroprotection, we have got erythropoietin, which is anti-apoptotic, antioxidants and anti-inflammatory agents, and drugs which support angiogenesis and neovascularization. So the term, now we will come to the term nootropics. That is the term used for the mechanisms by which we induce neuroprotection. So Comelius E. Georgia in 1972 introduced the term nootropics. They do not directly release neurotransmitters or act as receptor ligands. That is why they are effective even used later. So they do not directly release neurotransmitters or act as receptor ligands. They act by improving supply of glucose, oxygen, anti-hypoxic effects, and protecting neuraxis from neurotoxicity. They positively affect neuronal proteins, nucleic acid synthesis, stimulate phospholipid metabolism. They eliminate free radicals, anti-aggregation effects, and improve rheological properties and plasticity. Rheological properties of formed elements of the blood. We know that the smallest intracranial capillary is only 1 micron, but the size of an RBC is 7.2 microns. How it will carry oxygen? By its rheological property, it gets structured into a long snake and then manipulates itself through the small capillaries and provides supply to the nerve cells. So nootropics are also called smart drugs. Nous in Greek means mind. Tropins means monitor. They may be classified as the ones which are naturally occurring nootropics, the laboratory created compounds. Two groups of nootropics. One is naturally occurring and second is laboratory created compounds. And we have got a heterogeneous group of drugs produced in the laboratory. They are used in acute, subacute and chronic conditions, and they are well tolerated. So Ayurveda is preservation of health more than treatment of disease. So Ayurveda aims at preserving good health by good ways of living rather than treating ill health. So that is neuroprotection. So science of healthy living. Atharva Veda is based on the idea of balance in bodily systems and uses diet, herbal treatment, and yogic breathing. That is very well proven method of neuroprotection. So very limited caloric intake, purely sattvic diet, and then herbal treatment and yogic breathing. And Ayurveda, a natural system of medicine, originated in India more than 3,000 years ago. The term Ayurveda is derived from the Sanskrit word Ayur means life and Veda means science of knowledge. Then we have got neuroprotective agents in Indian literature. Then we will go to what is available in the allopathic system. So Brahmi, commonly used drug, all of us know, most people know that thing called Brahmi, which is commonly used, and it is a wonder herb known to stimulate memory and cognitive ability. It improves behavioral alterations and prevents oxidative damage. It contains, we saw the mechanisms by which apoptosis or programmed cell death is enhanced. That is antagonized. So anything that antagonizes the mechanisms which we went through now will be a neuroprotective agent. So contains powerful antioxidant, reduces inflammation, boosts brain function, helps reduce attention deficit hyperactivity symptoms, prevents anxiety and stress, helps lower blood pressure, and has anti-cancer properties. About 2 to 3 grams of Brahmi powder daily along with meal is neuroprotective, and it is used even in small children. Then curcuminoids and black pepper. Turmeric can increase the antioxidant capacity of the body. It is anti-inflammatory, antioxidant, and curcumin can boost brain-derived neurotropic factors, which we thought it is one of the naturally endogenous. We saw the neuroprotection may be endogenous or exogenous. Neurotrophic factors are the endogenous factors, and these drugs are the exogenous. Curcumin can boost the endogenous neurotropic factors and improve endothelial cell function, and prevents depression, aging-related changes, and Alzheimer's disease. And it has been used in India for thousands of years as a spice and a medicinal herb. Ashwagandha. Brahmi and ashwagandha can be taken together. They boost the brain activity. Brahmi and ashwagandha together help to maintain healthy functions of the brain. The side effects are nausea, increased stomach upset, and stomach motility. And next is dianol. Dianol is dimethylaminoethane, and it is a salt of tartaric acid that is present in the substance which is used to add taste to sambar and things like that. So that is salt of tartaric acid. It is a choline precursor and optimizes production of acetylcholine. We know that acetylcholine is the memory molecule in the brain. Next is L-carnosine. So L-carnosine is a dipeptide made of beta-alanine and 3-methyl-L-histidine. Beta-alanine and 3-methyl-L-histidine. It scavenges both reactive oxygen species and unsaturated aldehydes produced by the cell membrane lipid peroxidation. Reduces the rate of formation of advanced glycation end products and protects against oxidative damage and chelates toxic metals like iron. And it is a dipeptide molecule made up of the amino acid beta-alanine and histidine concentrated in muscle and the brain. And carnosine was discovered by the Russian chemist Vladimir Gluvich. And carnosine is naturally produced by the body in the liver from beta-alanine and histidine. It reduces the buildup of amyloid beta. It is having antioxidant property and favorably affect energy and calcium metabolism and reduces lactate accumulation. It has side effects in the form of stomach upset, headache, nausea, and vomiting. Its action is, as we saw, the dipeptide is made of beta-alanine and N-methylhistidine. Anti-inflammatory property, quenches the reactive carbonyl aroline, regulates macrophage function, scavenges both reactive oxygen species and unsaturated aldehydes produced by cell membrane lipid peroxidation. It reduces the rate of formation of advanced glycation end products and protects against oxidative damage, and it chelates toxic metals. So we have seen, so there are very many levels of protection at the level of the neuron, at the level of the astrocyte, at the level of the oligodendrocyte. And these mechanisms are metabolic support to neurons. So neurons, astrocytes, oligodendroglial cells, supporting cells. So it produces metabolic support to neurons, buffering, pH buffering in the cells, anti-inflammatory cytokine promotion, limits zinc and copper mediated toxicity, carbamylation related toxicity, free radical scavenging, NMDA toxicity, promotes brain-derived neurotrophic factors and nerve growth factor, and modulates neurotransmitters. And the beta-alanine component is a non-essential amino acid in protein synthesis and glucose metabolism. It is an inhibitory neurotransmitter in the brain. It is produced from pyruvate by transamination. It helps break down tryptophan and vitamin B6, and requirement is about 20 to 40 grams per day. So supplements to affect endurance adaptation. We say so many things are there. you can use beta-alanine is supplemented using various dietary components like juices, then caffeine, and various bicarbonate buffers, and a low dose of antioxidants. So there is some side effect apart from the stomach upset. It is said that it can produce some paresthesias. We should know when we use that, and we should be able to convince the patient that's a natural side effect, because a G protein coupled receptor from the MRGD family has been identified in the sensory neurons of the dorsal root ganglion, and beta-alanine appears to interact with this receptor, because the dorsal root ganglion receptor is activated by beta-alanine, patients can get paresthesia. So it is not having any pathological relevance. So patients should be counseled. And it has anti-fatigue, anti-pain, anti-glycation, anti-cross-link, and has chelating ability, maintains pH balance, and it is antioxidant and anti-stress. So possible protective substances for prion disease, ischemia-induced neurotoxicity, and Alzheimer's disease. So it can act on the brain and produce various effects, including the modified neurotransmitter environment in the brain with enhanced brain-derived neurotrophic factors. So its beneficial effects are seen in muscle, and reduces fat, improves muscle function, enhanced aerobic capacity, expanded power output, increased lean muscle mass, and reduce fatigue. So beta-alanine supplementation to improve exercise capacity and performance is by its action on the muscles. And then it acts on the citric acid cycle in the mitochondria and improves electron transport in the mitochondria. And histidine, so beta-alanine and histidine we saw. Histidine, L-histidine is used in the production of myelin sheath, which support the nerve cells. So the histidine component will help in remyelination. It acts on the digestive system, and it gives antioxidant support and gives support to the joints and ligaments. So the receptors are your H1, H2, H3, H4, and each one of them acts on various levels. H2 is mainly acting on the nervous system, and they produce appropriate effect on the end organ where they are located. So the dosage in children and adults, 800 milligram per day in 2 divided doses. And in adults, 1.5 to 2 grams a day. And it takes about 8 weeks to see effects. And duration of therapy is not clear. So you have got a beta-alanine, you have got L-histidine, and L-histidine is in the bloodstream. Beta-alanine needs hepatic breakdown, and this carnosine is synthesized. It is having action on the skeletal muscle and brain tissue. So the benefits are what we have already seen. It can prevent dementia, it can prevent fatigue, it can protect diabetes, it blocks cataract formation, and it is having an effect in as a psychotropic and cancer preventing effects. And the metabolic pathway of L-carnosine, we see the beta-alanine and histidine is there. They undergo methylation, then carnosine is formed, and it produces enzyme hydrolysis, resulting in the end products. And these end products, we saw that it acts as a mediator, participation in the allergic and inflammatory reaction, synthesis of coenzyme A, nucleic acid, and stimulation of collagen synthesis, and interaction with free radical producers. So indication is autism and learning disorders by improving language, auditory processing, socialization, and fine motor planning, expressive language, and awareness of the surrounding. And it prevents and treats attention deficit hyperactivity disorder, aging, eye disorders, complications of diabetes such as nerve damage, cancers, Alzheimer's disease, liver and kidney disease, and vascular diseases. we will get some examples. In vascular effect, a single PCA. Patient had a single PCA. Instead of both, all of us, most of us have two PCAs. So our patient had a single PCA. It was having bihemispheric supply, and patient had hemianopia, confusion, new onset posterior cranial headache, paresthesias, limb weakness, dizziness, nausea, swallowing defect, and memory loss. And this was the MRI showing the PCA infarct. And this was the fetal PCA, so bilateral PCA infarct, and there is cerebellar infarct, medial temporal infarct, and only hemiplegia. So this, at that time, we did not take the picture as the patient was very sick. And at the end of 2 months with the neuroprotection, patient had become very good, and he is on follow-up. And you can have the decerebrate or decorticate patients. So this is another patient who was decorticate at the time of admission with a huge cerebellar infarct, and he is like this now. He was decorticate at the time of admission. And side effects we have seen. So AD patients, as cardiac side effects are not there, we have tried Carnosine to many patients, and patients do show behavioral improvement at 6 months, decreasing A beta 142 induced toxicity in microglial cells, counteracting the oxidative stress and inflammation status, and antibody oligomers promote neuroinflammation and neurodegeneration. And L-carnosine rescues IL interleukin 10 levels in the A beta treated BV2 cells, and also reduced interleukin 1B, interleukin 6, and in interferon. And it slows the progression in Alzheimer's disease, but sustained effect is not seen after a brief period of stabilization. Patients as such progress as on the information that we know now. We have got unpublished data of 100 patients who were volunteers, and we had 25 AD patients, 25 FTD patients, and 50 patients with vascular disease, and they were evaluated with HMSC, EC, MOCA, comorbidity assessment, habits and duration mastering, and we found that it is most effective in patients with vascular cognitive decline. It works in patients with dominant hemisphere disease and posterior circulation defect than the non-dominant hemisphere disease. And it is useful even if started as late as 6 months after the ictus. And it is also showing significant change in language. And treated AD patients had a better activities of ABC means activities of daily living, behavior, and cognition than the conventional patients at 1 year. And FTD patients did not show appreciable changes. And our data on a series of 100 persons with dementia showed improvement in apathy, executive function, and memory in patients with vascular dementia. In stroke patients, improvement in language and balance was seen even 6 months after the insult. And children with autism spectrum disorder showed considerable improvement in behavior and cognitive skills. Next is nicergolin. It's an ergot alkaloid. It protects cultured neurons from beta amyloid. It improves nerves growth factor. It is useful in various types of diseases affecting cognition. It's a vasodilator, improves glucose utilization, and it is antioxidant. And personal experience, we find that it is very useful in the management of atypical PD, where the treatment choices are very less. Then piracetam is a derivative of gamma aminobutyric acid. It improves the function of neurotransmitter acetylcholine via muscarinic cholinergic receptors. Its effect on N-methyl D-aspartate glutamate receptors are involved with the learning and memory process. And it improves cognition and memory. It improves dyslexia, mental disorders, and myoclonic seizures. Acts on calcium ion channels, enhances acetylcholine, and ATP is favorably influenced and improves electron transport in the mitochondria via cytochrome B5, and it is well tolerated. And its role in CVA, piracetam has effect on the vascular system by reducing erythrocyte adhesion to the vascular endothelium, hindering vasospasm, and facilitating microcirculation. Vast experience in CBA over 3 decades with this drug yields excellent results. And however, data has not been methodologically analyzed for constraint of time. And intravenous 4 to 8 grams per day with maintenance of 2 to 4 grams for 2 to 3 weeks is the recommended dose, and it is useful long after the window period. Citicoline stabilizes cell membranes by increasing phosphatidylcholine and sphingomyelin synthesis. It is intermediary in the biosynthesis of phosphatidylcholine, stimulates biosynthesis of structural phospholipids of the neuronal membrane, and it preserves the neuronal energetic reserve, inhibits apoptosis, stimulates synthesis of acetylcholine, and it is also claimed to increase blood flow and oxygen consumption in the brain. 100 to 1000 milligram daily, slowly IV, over 3 to 5 minutes, or as infusion with a rate of 40 to 60 drops per minute, and 500 to 1000 milligram by mouth twice daily for 12 months. Edaveron. Edaveron is 3-methyl, 1-phenyl, 2-pyrosine, and 5-1. Is a potent scavenger of free radicals and inhibitor of lipid peroxidation. CVA scavenging in cerebrovascular accidents. It is useful in preventing cerebral edema and inhibits delayed neuronal cell death. It is used in the treatment of amyotrophic lateral sclerosis, and it has to be repeated for 6 months, every 2 weeks, every month for 6 months in ALS. Ginseng. It improves nitric oxide production, increases the activity of superoxide dismutase, improves physical and mental resilience, and the dose is 120 to 300 milligram per day. Other drugs in this series are vinpocetine, pyretinol, naftidofural, dihydroergotamine, phosphatidylcholine, ascorbic acid, and alpha tocopherol and caffeine. So I have not elaborated the last group of drugs because I have no personal experience using them. The rest of it I have used them myself. So one's goal of human birth, one's main purpose in human life should be to purify existence and achieve liberation in this material world, to render service to the lotus feet of Govinda, the cause of all causes, and to see him everywhere is the only goal of life, according to Srimad Bhagavatam. So gross material science cannot divert the real purpose of human life, and they can only increase the artificial needs of life without any solution to the problems of life. So how long we will protect the nervous system, how much we will protect, and what is the purpose, all that depends on the ultimate goal set by us. So we have to decide how long, how much, what. So human life is meant for reviving one's eternal relationship with the Lord, and all religious injunctions are meant for awakening this dormant instinct of the living entity. So neuroprotection in daily life, use if you don't want to lose. So be active. If you become lethargic, dull, and you say that now it is, I have worked enough, I want to relax, then you are going to rust. So don't rest if you don't want to rest. Use if you don't want to lose. And let nerves fire so that they wire. If the nerves are not firing, they will not wire. There are no synapses and apoptosis will be enhanced. Be vegetarian. Reduce sugars, salty foods, alcohol, processed red meat, organ meats, shellfish, and beer. Not reduce, don't use at all. And Alzheimer's disease results probably from a maladaptation to an evolutionary survival pathway, which happens with this type of diet. Plant-based whole foods are ideal. Exercise, ultrasound, photobiomodulation are all new promising techniques in neuroprotection. And avoid food containing monosodium glutamate like Lay's, noodles, all these artificial taste makers. In fact, monosodium glutamate is the rat model for Alzheimer's disease. And use Mediterranean diet. Mediterranean diet is a way of eating based on the traditional foods and eating patterns of the people and countries surrounding the Mediterranean Sea. That is Spain, France, Italy, and Greece. They ate lot of fat, healthy fat, fruits, vegetables, nuts, seeds, legumes, and whole grains. Neuroprotection in daily life, maintain proper weight by following a healthy diet, exercise regularly as it helps in less cognitive decline and brain volume loss, avoid smoking and alcohol, avoid stress by practicing meditation or yoga, include food and fruits and vegetables, eat nutritious food as it helps in cognitive stimulation, limit foods with high cholesterol and saturated fat, cut down on sugar, salt, and processed food, follow a healthy lifestyle as it helps in improving overall health and possibility of protecting the brain. And do not take alcohol, smoke, and other substances and drugs of dependence. Wear helmet to avoid head injury. Adopt safe sexual practices. Take care to treat ENT, dental, and other systemic infections to prevent access to neuraxis. Then treat diabetes, hypertension, heart disease, asthma, and dyslipidemia properly. Take fiber and vitamin-rich balanced diet with vegetables and fruits. Exercise regularly for at least 15 minutes. Remain active always. Keep learning, discussing, and participating in social activities. Cultivate the habit of positive thinking, as negative thinking makes your brain age faster. Engage in extracurricular activities, music, yoga, crossword puzzles, reading and writing. Can use dietary supplements, blood thinners if your physician feels it is indicated for you. Consult your doctor when you find anything going out of pace, like activities of daily living, decision making, sleep, personality, and communication skills. So, Human Cognition, as we understand today, is a book that I have written, and this is a foreword published by a book review published by an author in the psychology journal on my book, and this is my book. So anybody interested can contact this number and get the book. Then the truth of life is ponder over your real nature. So that is, your nature is absolute purity and love. Your real nature is not violence, not killing, not damaging, not competing, not running after materialistic goals. So if there are any doubts, we can discuss what I know. Thank you.